Tainá. So
Okay.
just wait a few seconds here.
So Sheifali, Tainá, Dorry, and then Marina, or Dorry at the end?
Then Dorry and then Marina at the end.
Okay. Okay.
You're going to have a mixed.
Understood.
And TTS, ABTO, TTS speakers.
Okay, great.
So people are coming in right now. We can start right now. Thank you, everyone, being here with us at our special webinar on the ABTO TTS joining together today so we can talk about a very important topic that hit us 2 years already. We are 2 years on the impact of COVID, and today we're gonna have the opportunity to talk about this in the way that we need to work on. So I'd like to welcome here Dr. Marcelo Cantarovich. He's the president of TTS, and we are very happy to have him here today to share some of his thoughts on this topic. Thank you, Marcelo. Welcome.
So thank you so much, Gustavo. It's a great pleasure to be here with you. This is a joint webinar between the Brazilian Transplant Society and the TTS. And without further ado, I would like to introduce the first speaker. But just before that, I would like to remind you of the TTS Congress in Buenos Aires, not that far from Brazil. You know where it is. We have a big issue with football, but we are friends outside of the football stadium, and we hope that we will be welcome you all in Buenos Aires. It's a lovely city. This is the Congress slide. Thank you so much for showing it. And without further ado, it's a great pleasure to introduce to you Sheifali Sandal. So Sheifali Sandal is associate professor of medicine in the division of nephrology, multi-organ transplant program at McGill University. She trained in New York State, and then her fellowship in kidney transplantation was at McGill University. And after that, she spent about a year of a fellowship in research with Dorry Segev at Johns Hopkins. And it's a great pleasure to work with her. She is a rising star, and you will see when you listen to her presentation. Sheifali had the idea of organizing a global survey that was completed about 2 years ago at the beginning of the pandemic, and she has updated some of the data, and today she will show the impact of the global impact of COVID-19. Thank you, Sheifali.
Okay. Hello, everyone, and again, thank you so much for inviting me to present on this subject. I have just one disclosure. I've gotten an education grant from Amgen Canada. And here is the beginning of the presentation. So I'll start with why we decided to pursue this survey. And actually, I was pregnant when we decided to proceed with this study, and I was almost about to deliver. Anyway, so early days of the pandemic, one of the biggest questions that most transplant centers faced was whether to perform transplantation or not. And there were several reasons for that. Do we really want to introduce immunosuppression in the midst of a pandemic? What are the risks versus benefits of postponing the transplant for a couple of months versus doing it right now? And then there were several other nuanced allocation schemes because of all the resources that were being directed towards ICU, and several uncertainties existed about the virus itself regarding screening, regarding outcomes, regarding the risks of transmission. I remember early in the day, people didn't even think that community transmission was possible. They thought it was all nosocomial. So some of the early work that came out of Dorry's group, actually, what they looked at was what did the COVID pandemic do to early transplant activity? And each dot here represents a transplant program. And what they asked the individuals who took the surveys, how much did the pandemic affect your transplant activity? Black dot means that complete shutdown of the program, no transplants were performed. Red means that the transplants were performed, but with some restrictions, and blue means that transplants were performed, and there were no restrictions. And as you can very easily appreciate, during the early days of the pandemic, most programs had to cut down on their activity, and some, especially the living donor kidney transplant programs, really had to just shut down. Similar work came out of the Alexander Loupy's labs. So the left is France and the right is US. And in the red, what he and his group looked at is what happened with the COVID cases. And from February onwards, as the COVID cases started increasing, there was a simultaneous decline in the number of procured organs. So this is all the early data. And when me and Marcelo used to talk about this, all of this data is arising from resource-rich countries. What's happening in other countries, with is often referred to as the developing countries or lower income countries. So that was what was the aim of our survey. We wanted to assess the impact of the pandemic on transplantation, but by a country's income level, as well as their cumulative COVID-19 incidence. And the reason we picked income level is because it's a good surrogate measure of the expenditure in health and the vulnerabilities of a health system to a pandemic. So one of the first things we did was we asked ourselves, it's very difficult to ask people in the midst of a pandemic who are being redeployed. I had colleagues being redeployed to do COVID wards. It's very difficult for us to ask them, can you count the number of transplants you've done in the first few months? So we wanted to come up with surrogate measures of activity without that people can easily respond to without having the pressure of counting the number of transplants. We have a great database manager, and I know many programs do, but that might not be the case in all countries. So what we came up with is 4 questions, and some were subjective and some weren't. So the first question we asked was, what do they anticipate their transplant volume would be? Would it be at least 75% of what they normally do? Have they performed any transplants in the early days of the pandemic? What were they able to maintain a their pre-pandemic deceased donor offers? This was a subjective response. And the last question was a yes, no. Were you asked to ramp down transplantation by your hospital, by your center, etc.? So we had a lot of other questions, but this is what I will focus on for this talk. And we conducted this survey from June to September 2020. And this is our study flow diagram. We actually didn't know who to send the survey to. So it was one of the most interesting part was the recruitment aspect. So we contacted a bunch of societies and we asked for their help in identifying individuals who are decision makers in the program. And we focused on one individual per transplant program. So a center could have 5 programs: a heart transplant, liver transplant, lung, kidney, pancreas. So 5 different individuals could take the survey, but we made sure that that no 2 people from the kidney transplant program, for instance, take our survey. So we were able to successfully contact 1,289 individuals, of which 513 completed the response, and those were the surveys we analyzed. I want to point out that we wanted to make sure that we got a good representation of non-kidney programs, programs that were in countries that had a very COVID-19 burden and a varied income level, and we were able to achieve that. So here is the sort of like a grid of where we got our responses from. And even though we got quite a few responses from the US and Canada, we also actually managed to get a lot of responses from my native country, India, and Brazil as well. So we did get quite a few responses from many countries all across the world. And we got a good representation of non-kidney programs. We had around 20% of the individuals who participated were identified themselves as specialists in liver transplantation. We also ensured that we got some pediatric physicians to take our survey. And we did get a good spectrum of individuals who were in low or lower middle income countries, upper middle income countries, and high income countries. And for the cumulative COVID-19 incidence, we looked at the Johns Hopkins map and we supplemented it with data coming out of India area, and we divided we looked at the cumulative COVID-19 incidence and divided it into 3 tertiles. So this was the background characteristics of the people who took our survey. But what was the response and how did it vary by the income level and the cumulative COVID-19 incidence? So here are those 4 questions again, and on the bottom of this chart or this table, what you can see is that in bold are things that are significant. So the cumulative COVID-19 incidents didn't really change the responses, except this one right here, where some individuals from areas that had a medium cumulative COVID-19 incidents, they were less likely to say that they were able to maintain their pre-pandemic deceased donor offers. But the more pertinent point that we want to make here is that the income level was associated with all responses, and it was associated such that lower and lower middle income countries were more affected. So for instance, if an individual who was from a program that was located in an upper middle income country or a lower middle income country was much less likely to say that they will be able to maintain their transplant volume. They were also much less likely to say that they had maintained their pre-pandemic deceased donor offers and that they were able to avoid a ramp down phase. What they were more likely to say is that we did not perform any transplantation. So the income level of the country seemed to affect transplantation, these surrogate measures of transplantation. The type of organ also may be associated with the responses. So kidney transplant programs seem to be disproportionately affected, especially for this particular response on whether the program was performing transplants or not. The age group of the recipients was not associated with the responses, and neither was the type of health system that the program was located in. But the next 2 slides are very interesting. So what we asked our respondents were to rate on a Likert scale, which was from strongly disagree to strongly agree, with a neutral in the middle. And we looked at the literature. There was so much literature coming out on COVID and transplantation, and we identified what people thought were the current risks to their program and what are the anticipated risks to their transplant program. So even here, the COVID-19 burden didn't seem to change the level of agreement, but the income level of the country did. So a question like this, obviously, what is we asked them to rate the level of agreement on the burden of COVID-19 patients is high in their region. So obviously a person who's from a high COVID-19 incidence area will have a higher level of agreement with. But other than that, the respondents, the level of agreement for all questions stayed the same. What did vary was the income level, and negatively so. So for instance, ICUs in my area are overwhelmed. This response right here. People from lower income countries were more likely to agree with this statement than those from upper middle and high income countries. And this is what we asked them when we asked them, what are the anticipated risks to your program? So again, we did a needs assessment review of the literature. We looked at what people think will be the anticipated risks, and we created statements and asked them to rate them on a Likert scale. Now, this survey is conducted between June and September. There were no vaccines then. But even then, I want to point out this particular response, because we have speakers talking about this, that a lack of vaccine to COVID-19 was anticipated to be a huge risk to the program by individuals who were in low and lower middle income countries. So 83% of our respondents agreed with the statement that vaccines will be a risk to transplantation in their region, in their country, to their program. And you know, there's a lot of talk about vaccine equity, and I know like this is not the forum for it, but perhaps this is the forum for it as well, because as of early March 2020, I believe 11 billion vaccines had been administered, and of these, 79% of the first vaccine. So in high income countries, 79% of the population had received at least one dose of the COVID-19 vaccine. And in lower income countries, this paper states that only 14% of the population had received the first dose of their vaccine. And then they looked at, you know, we are talking about booster doses, whereas people in lower income countries actually haven't even had their first dose yet. So in this paper that just came out last month, the authors reported how many individuals, how many population had received the boosters per 100 people. And clearly the high income countries are right here, much higher, whereas the low income countries are right here, where most of the population hasn't even received their first vaccine dose. So we also, just a quick word about education. We also asked the individuals who had trainee programs, do you think that the pandemic will affect the training of your fellows or your residents? And again, the responses didn't vary by, whether there was a surgical specialty or not, but varied by the income level. So people who were in lower middle income countries were more likely to say, yes, the pandemic will affect my trainees' experience. So our conclusion was, it's something very intuitive, but we were able to show it with a survey. So most transplant programs globally have incurred damage, collateral damage from the pandemic, but this impact is much more in lower middle income countries, independent of their cumulative COVID-19 incidents. And it seems that kidney transplant programs may be more affected. Why? Because in many places, dialysis is available. And the relevance of this topic is very, very, very important. Why? Because in 2019, over 150,000 transplants were conducted annually, which means around 17.5 transplants are conducted per hour. So if all transplant programs shut down just for 1 week, 2,800 something, almost 2,900 less organs will be transplanted. And this is a huge problem in many countries where there's no availability of things that can bridge you to transplantation. So dialysis might not be available to some patients, LVADs might not be available to some patients. So those patients, if they don't get a transplant, they die. So that's why I think we're going to get the more objective data. I'm sure it's coming out already, but we will get more data showing that our patients who were candidates, who were on the wait list, more patients actually died, not that they didn't get a transplant. And we know that because the cumulative estimated excess deaths is higher in lower middle income countries than in high income countries and upper middle income countries. It was interesting in this curve that the low income countries are right here, and the authors themselves postulated it's not per se perhaps because they weren't captured properly, because many governments are not that forthcoming with the number of deaths that their country has had. But regardless, in lower middle income countries, one can easily appreciate that there is a cumulative excessive burden of death, and it'll be interesting for us to see and humbling for us to see that our patients have actually died while waiting for a transplant. So it's not just that we did less transplantation. So, and is this a surprising finding? Absolutely not. Every other field that was not COVID had collateral damage, and there is literature coming out in the oncology literature, the TB, the HIV literature. They're all talking about the devastating impact that the pandemic had on the care of these other patients, similar to what our data has shown as well. So with this, I'll conclude this talk, and I just want to give a shout out to the Brazilian Association for Organ Transplantation, because they did help us with the administration of the survey, and to all the other individuals who helped us identify people who should take the survey. And we want to thank the 500 plus individuals who took the survey in the middle of a pandemic. So thank you very much for that. And I look forward to the next talks.
Well, thank you so much, Sheifali. I believe we'll save the questions to the end, right, Gustavo? Or now?
Perfect. Yeah, sure. We can do it in the end.
Thank you.
Thank you very much, Sheifali. It's a great presentation.
I know I went by fast, but it's because I really want to hear the rest of the speakers.
No, thank you. Thank you. So now I'm going to present Dr. Tainá de Sandes. She's from Ceará, the northeast of Brazil, and she made us a great job on our Brazilian registry. Thank you, Tainá, very much for your time here.
Thank you, Gustavo. Sorry, just to check if my presentation is correct for you.
Yes, it is.
Okay. Thank you, Gustavo. Thank you for inviting me to be here. It's a really pleasure to share this meeting with such qualified experts. When you, Gustavo, invited me to join this webinar, this webinar today, our first webinar to discuss COVID, you remember, sure, just over 2 years ago, immediately came to my mind. As you can see in these photos, our faces reveal worry and concern, probably because of the lack of information about COVID-19 at the time. And at that point, as Sheifali mentioned, our concerns were focused on the maintenance of the transplant program, but we also had no information on the potential modulatory effect of the immunosuppressive drugs on the clinical presentation, don't know how to treat, don't know how to manage, etc. So at that time, on March 2020, we had few cases, few COVID cases in kidney transplant patients in Brazil, but we predicted that we could help answer some of that questions given the dimension of our transplant program. So we built this multi-center registry database, including patients tested positive, symptomatic patients who tested positive for COVID-19. And currently, this registry has almost 6,000 patients from 44 Brazilian centers, from 4 regions, Brazilian regions. And this graph in red illustrates the distribution of COVID cases over the time. And up to now, the main results of our database have contributed to our knowledge to answer some of questions listed in that first slide. So this presentation now brings the findings of our main analysis, which aim to target to answer these specific 6 questions highlighted here. Who are those patients? Are clinical, laboratory, and radiological findings atypical? Are outcomes worse or better than in general population? What are the predictors of death? Immunosuppressive regimen effect, the outcomes, and if there is any impact on allographic function. Addressing that first question, so who are these patients? The demographic characteristics of our patients are similar to that described to non-transplanted patients. There is middle-aged men, overweight or busy, with comorbidities such as hypertension, diabetes, cardiovascular disease, in line with other international registries. Interestingly, they are long transplant patients, certainly because they are more likely to have an active social and work lives and are more susceptible to be affected. Concerning to clinical presentation, signs and symptoms are shown in this graph, left graph, and lab and image are on the right. And except for a high incidence of diarrhea and acute kidney injury, both highlighted in red boxes, our data demonstrated once again that clinical presentation is very similar to that reported to non-transplant patients, suggesting that immunosuppression Cs do not significantly modulate clinical findings or clinical presentation. Moving to outcomes, it seems to be increasingly clear that transplanted patients have worse prognosis than in general population. As demonstrated in this graph, there was an improvement in the fatality rates in the first months of the pandemic. This was our data. And we debate whether this findings is a consequence of a change in demographic profile, early diagnosis, availability of COVID tests, and learning curve, better treatment, the management or non-invasive mechanical ventilation, the use of steroids, anticoagulation, etc. But when we compared to that report to the general population, transplanted patients had a 6-fold higher mortality during the first and second waves of the pandemic. And during the third wave, in the context of post-vaccination status and Omicron variant, there was a significant reduction in the fatality rate, decreasing from 21 to 80%, but it's still significantly higher than the general population. So in fact, considering that proportion, it does seem that the impact of the infection on transplanted patients is even greater now. Just to clarify for all what we consider here as first, second, and third waves, as these chains among countries, This graph illustrates the distribution of COVID cases among kidney transplant patients from the beginning of the pandemic to now. This distribution of cases over time is very similar to what occurred in the general population in Brazil, demonstrating this graph on the right. And we consider the first wave, the cases until October 2020, the second wave from then to December 2021, and third wave from December up to now. Importantly, the Brazilian national vaccination program started in January 2021, prioritizing at that time the elderly and healthcare professionals. And non-elderly kidney transplant patients started vaccination only in April to May 2021. Okay, moving to another question, another point. What explains such a high mortality? We know that these patients have more comorbidities, as you know, and they also chronic kidney disease per se is a risk factor for death, and these could explain the higher mortality among transplanted patients. However, when we compared our patients with a cohort of dialysis patients matched for age, gender, ethnicity, BMI, and comorbidities, the transplanted patients showed an increased risk for death, suggesting that other factors that distinguish these patients, such as the long-term immune suppression, may negatively influence outcomes and may explain these worse results. Speaking on immunosuppression, in this analysis, we evaluated the baseline immunosuppression and its association with mortality, immunosuppressive regimens. And we found that patients on mycophenolate are more likely to die after COVID-19. This is baseline immunosuppressive regimen. And in fact, some papers show that patients on mycophenolate have lower seroconversion rates after vaccination, suggesting a potential impact of this drug on the immune response. Okay, and interestingly, patients on mTOR inhibitors had better survival, and we still don't fully understand the mechanisms involved in this protective effect. We have some hypotheses, but I think further investigation is necessary to better understand. So after identifying the risk factors for death, including immunosuppression and the traditional variables associated with worse prognosis like age, BMI, comorbidities, renal function, clinical symptoms, we designed a software to estimate the probability of dying. Our goal here was to predict, based on information obtained remotely by phone, which patients need a face-to-face medical evaluation, optimizing the logistics of the centers and ensuring hospital assistance to high-risk patients. And the link is here in the bottom right. But still about risk factors, we analyzed 20 patients who were inadvertently transplanted with a positive PCR, named here as pre-KT COVID group. These patients were asymptomatic at transplant time, and they had a PCR collected before the transplant, but the results used to take some days. So they were checked after the transplantation. And 130 developed clinical symptoms, but the outcomes were pretty good without deaths. Differently, the outcomes of 49 patients who acquired COVID in the first month after transplant, named here post-KT COVID-19, were not so good. As demonstrated in the orange bars, almost all became symptomatic. Half of them required invasive mechanical ventilation and intensive care, and 39 died. So these findings suggest that the high doses of immunosuppressive drugs commonly used early after transplant, including induction therapy with thymoglobulin, have distinct effects in these two different groups of patients. And also, these results lead us to reflect on the possibility of considering transplanting asymptomatic patients who tested positive for COVID during these screening tests. Finally, the long-term impact of COVID on allograft function and survival. The preliminary data of 1-year follow-up after the infection demonstrate a low rate of graft loss, despite high incidence of acute kidney injury, including high rates of dialysis requirement. The majority of patients recovered renal function. Importantly, most graft loss came about in patients with poor baseline renal function, demonstrated by the high baseline creatinine that grew 3.1. And there also does not appear to be any significant additional mortality beyond 90 days. So coming back to the first slide, more than 2 years have passed since this first webinar, ABTO webinar. And here, these photos were taken 1 month ago during a panel to discuss COVID transplantation, and reveal a more relaxed mood, probably because our initial questions were almost all answered. But do we know that new answers arise every day and will continue to rise for a long time? But I am sure and confident that through collaborative efforts, the Presidente Transplant Program will go through this difficult period and overcome one more challenge. So I'd like to thank all these participating centers, our research team, all supporters, our sponsors for the engagement in this study, in this project. Thank you.
Thank you, Tainá. Great job. Great job. Thank you very much. Marcelo, you're muted. Can't hear you. We can't hear you.
So I'm sorry for that. It gives me great pleasure to introduce a friend, Dorry Segev, who's professor of medicine at NYU, who's also a TTS counselor, mentor of many, very active researcher who does not really need any introduction. He's one of the top people publishing in the field of transplantation, and I'm really happy to present him, introduce him, and he will talk to us about the COVID vaccination, what are the lessons that we learned. And Dorry, the mic is yours.
Thank you, Marcelo and Gustavo, and I've enjoyed the talks so far from the other speakers, and I'm looking forward to Marina's talk at the end as well. It's great to see a lot of familiar names in the participant list, and to meet some new friends also. And I hope to see everyone soon in the next year at some in-person meeting or another, whether it's in Lençóis Maranhenses Park, which is what you're seeing in my background, or whether it's in Buenos Aires for the TTS meeting. Marcelo and I already have thrown down the gauntlet for a tango competition. So even if you don't care about the science, if you want to witness this level of high profile entertainment, you should come to Buenos Aires. So I was asked to spend a few minutes talking about COVID in the United States, the impact that the pandemic had, vaccine responses that we learned about, and then what I call learn from home. Everybody got to experience work from home, and we got to experience science from home. This is our COVID observational study team. We started at Johns Hopkins, and then I've moved to NYU, and Jackie Granza-Guang, who also helped me start this, moved to Wisconsin, and now this is a multi-center, large national effort. Early on in the pandemic, just like in other countries, Olivia Cates showed that in the United States, solid organ transplant patients had very bad outcomes with COVID-19. And then as you saw from Sheifali's talk, this caused transplant centers to nearly shut down in the United States as we figured out this pandemic. Things got better. You're looking at late 2020 mortality data from Hopkins that Robin Avery looked at, and mortality at Hopkins was 5 to 7% until Omicron came, and then with Omicron things got better, and mortality has now been about 2% in our experience. This is work of Willa Cochran at Hopkins. But you know, comparing this to the general population view that Omicron is just a cold, this is not just a cold, obviously, in our patients. And when Alan Massey looked at excess deaths, and so this is the number of deaths we observe versus the number of deaths we would have expected were there not a pandemic, you can see that every month there have been excess deaths attributable to COVID-19. Throughout the pandemic. So again, causing a great deal of fear and concern and trepidation in our country, just like with the data you heard about Brazil and from all over the world. And then came the vaccines, and this was the ray of sunshine for the immunocompetent, but those on immunosuppression were excluded from the randomized trials. And we know that vaccine responses require immune responses, and in general, we have lower vaccine responses in transplant patients. And so very early on, we worried about safety as well as immunogenicity in our population. We were doing research in December of 2020, and Jackie Gronzik-Wang and I discussed the implications of this. So this was during the height of wave 3 in the United States, where it was dangerous for transplant patients to even leave the house, let alone go to a center, get their blood drawn, participate in a trial, et cetera. And also because of the way we did the vaccine rollout, only a few patients from each transplant center had access to the vaccine. And so we had to turn to national recruitment using social media to gather enough patients that we could learn from. And so obviously we had to learn from home, meaning the patients couldn't come to us, we couldn't come to them. We had to figure out how to do research on patients who were at home. In the first week, we had more than 1,000 patients enroll in our trial. How many times have you seen any study accrue more than 1,000 patients in the first week of enrollment? We had to see them for reactogenicity visits, and we had to get blood from them for immunogenicity. We leveraged a relatively new technology that I call the mechanical leach. That is a capillary blood collection system that patients can do painlessly at home. We would send them a number of kits, and then every time we needed a blood draw from them, they would stick this thing to their arm like you see demonstrated here. They would get 200 microliters of blood, send it to us in the mail, and we would be able to do all the science that we needed to do. By February, so vaccines came out in December. By February, we already had published safety data showing no evidence of alloimmune activation as a result of the vaccines, and a reactogenicity profile that looked like the general population. By March, we already had published data in JAMA, work of Brian Boyarsky, showing that the first dose was not immunogenic compared to the immunogenicity in the general population, and then followed in May with second dose data, also in JAMA, showing that vaccine immunogenicity in our patients was suboptimal. You're seeing here the antibody results, and after the blue lines are the ones who had a response after one dose, and then the pink dots are the ones who had no response after one dose, but did have a response with 2 doses. And you see that about 1/4 of transplant patients reached that level that we called off the charts, where they had the highest detectable level of anti-SARS-CoV-2 antibody. 3/4 of them demonstrated far suboptimal immunogenicity. When Sanjay Bay and Jenna Leho took data on thousands of patients and put them into a machine learning model, we learned that being on MMF, being closer to your transplant, being of older age, and the vaccine platform that you received were associated with vaccine responses. And we have this calculator that you can use online that you can enter the information about the patient, and it will tell you the probability of any detectable antibody after a 2-dose mRNA vaccine series. After our original reports, a number of reports across the United States and even across other countries started to demonstrate very similar things, that the immune response was suboptimal when it came to detectable anti-spike antibody. Andrew Caraba in our virology lab showed that anti-spike antibody correlated with neutralization. So if you had low antibodies, you had low neutralization. If you had high antibodies, you had a much higher chance of having neutralization. And this spread across the wild type, alpha, gamma, and delta variants. I'll show you Omicron data later. The Moderna group in the general population published in Science that not only did antibody levels correlate with neutralization, but they also correlated directly with clinical protection. For every 10-fold increase in any of these biomarkers, there was about a 40% decrease in the likelihood of a breakthrough clinically significant infection. Now, this is in the general population. We did see the impact of this, albeit a little bit more indirectly in the transplant population. Carolyn Chin, one of our medical students, gathered data on 18,000 fully vaccinated transplant patients across 17 hospitals. And she showed that the risk of a breakthrough infection comparing fully vaccinated transplant patients with fully vaccinated general population was 82 times higher. And the risk of a breakthrough infection with associated hospitalization or death was 485 times higher. Now, bear in mind, when you look at JAMA papers and stuff, usually the relative risk is like 1.8, and it's a huge deal. Like, if it's twice as high of a risk, that's a big deal. This is 485 times higher of a risk. So that's a big, 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 big deal, bigger than anything really that we've ever seen in our field. Those on Bella did far, far worse in terms of antibody responses. Those receiving the Johnson & Johnson vaccine actually did even worse than those receiving the mRNA vaccine. Interestingly, pediatric patients actually had better vaccine responses than adult patients, although still quite suboptimal compared to the general population. Bill Werbel studied the patients in our cohort who then went and got third doses. And it's a very interesting story because these people violated US policies and lied that they never got a vaccine and got a third dose. And the data from these patients was sent to the FDA and the CDC and motivated the change to make third doses allowed. So it's a very US cowboy spirit that says, I'm not allowed to have a third dose, but I think it's a good idea, so I'm just going to go do it. And then the data from those cowboys was the thing that was used to motivate the change in policy. So we know that third doses show increased immunogenicity. So another immune priming episode improves immunogenicity. It even does so for those who started with the J&J vaccine and then moved to an mRNA vaccine for an additional dose. This ultimately did then change FDA and CDC policy, which then allowed transplant patients and other immunosuppressed people to receive third doses. When you look at the third dose data, some people do very, very well, but you see here there's still a group of patients who have suboptimal immunogenicity even after a third dose. And then the questions become very obvious. Well, is heterologous third dosing better than homologous third dosing? This just got accepted into AJT, so you can see in the next couple of days, you'll see all of the details of the data. But what you see here is that heterologous boosting with the J&J, if you started with the mRNA, was actually superior to homologous boosting with another dose of the mRNA. So sort of hinting at maybe different biologies there. We know that those on higher dose MMF have worse antibody responses than those on lower dose MMF. And so all of this caught the attention of probably the most respected and most overworked person in the world in the last 2 years, which was Anthony Fauci, who gave us funding to launch a randomized trial of immunosuppression reduction. So in our trial, those on MMF, they get their MMF turned off 2 weeks before and after the booster dose. And then we'll have data in the next couple of months to see if immunosuppression reduction is safe, if it activates alloimmunity, which would be bad, or if it helps the vaccine immunity. We've been looking at fourth doses because those have recently been approved, and you can see that antibody levels go up with these fourth doses, but sadly, in the era of Omicron, they don't reach a point of immunogenicity that is associated with neutralization. So even with a fourth dose, in those who didn't have a good third dose response, we cannot prime them to a neutralizing response against Omicron. Some people are trying a fifth dose. In the handful that we've looked at, there have been some improvement in their anti-spike antibody, but we haven't had a chance yet to look to see whether this correlates with neutralization. So we're trying all sorts of different ways to prime the immune system to improve immune responses to the vaccines. Clearly, COVID had a major impact on transplant practice with high mortality in our patients, improving outcomes, but still not benign. We can learn a lot from studying 8,000 people we never met. This is learn from home. I'm giving an entire lecture at the TTS conference. Remember that conference I happened to mention that's happening in Buenos Aires that I'm sure Marcelo is very glad that I keep mentioning. At that conference, we're going to talk even more broadly about what this learn from home means in terms of the future of our field. We know the vaccines are safe, but generate poor antibody responses in our patients. Antibodies do correlate with neutralization, which does correlate with clinical protection. And we've seen substantially higher rates of breakthrough infections in our patients. There is some improvement with additional doses, but some of our patients, and probably many of them, will no doubt need other immunity strategies like immunosuppression modulation, heterologous vaccination, or passive immunity with monoclonal pre-exposure prophylaxis that has just recently been approved in the US, and we're studying the impact of that on transplant patients now. The latest ethical debate that has occurred in the United States is whether we should be requiring vaccines for our patients. There are a lot of data supporting vaccine requirements in the US now. About 40 to 60% of centers have some sort of vaccine requirement. Much better COVID outcomes in those with good vaccine responses. Vaccine responses pre-transplant are much better than vaccine responses post-transplant. There is an especially low chance of a vaccine response early post-transplant, high death rates with breakthrough infections, 10% death rates in breakthrough infections, even in fully vaccinated transplant patients. Persistently positive patients can incubate and shed variants and harm others. And in the United States, in our regulatory environment, there is a programmatic reason to require vaccines as well, because if their patients die of COVID-19, they get flagged by the regulatory agencies and they actually are at risk of losing their entire transplant program. So those are some of the data on vaccines and the impact in the United States. Again, a huge thank you to all of the people involved in the data that I showed you. And I almost forgot to mention the TTS meeting is in Buenos Aires in September, and here is yet another reminder of that and why you should go, and the soon-to-be epic tango competition between myself, a lowly counselor of the society, and the president himself. So thank you. Muito obrigado.
Thank you, Dorry, and let's not make it a big challenge, okay? But we'll do our best. Gustavo.
Sure. Thank you, Dorry, very much for your presentation. And now we're going to hear Marina talking about our vaccine, the Brazilian vaccines, how we've done with our vaccines. Marina, thank you.
So Good evening, all of yours. Thank you very much, ABTO and TTS, for the invitation. It's an honor for me. I would like to do my presentation in Portuguese to better reach the Brazilian audience, but I am available for further discussion in English o en español si quieres después. But Segev, I would like to challenge the US cowboy, because now I will present my Brazilian caipira vaccine. And so let's start. Nos próximos minutos, eu vou comentar sobre os resultados da nossa iniciativa de vacinação entre os nossos pacientes transplantados renais. Esses são os meus conflitos de interesse. E
Marina,
eu gostaria...
A sua apresentação está parada na primeira página ainda.
Sério?
Você consegue desfazer e fazer de novo?
Sim, com certeza.
Não,
Um minuto.
Acho que...
Um minutinho. Me avisem.
Agora ok.
Ok.
Pode passar para ver se está funcionando.
Tá funcionando?
Passou. Sim, ok.
E eu gostaria de quebrar o protocolo. Eu sei que os agradecimentos vêm no final, mas não consigo não começar agradecendo aos mais de 300 voluntários que trabalharam nesse projeto da iniciativa da vacina, ao Instituto Butantan e ao time do Hospital do Rim, que trabalha incessantemente durante esses quase 3 anos de pandemia em prol dos nossos pacientes. E qual foi a motivação principal para isso tudo? A motivação principal está resumida nesse slide. No final de 2020, a COVID tinha afetado 10% dos nossos pacientes em segmento, pacientes que conhecíamos bem, e tinha levado a óbito 1 a cada 4 receptores de transplante renal do nosso centro. Esse gráfico, ele demonstra a comparação da taxa de letalidade dos nossos pacientes transplantados em rosa com a população geral do estado de São Paulo. E a letalidade pela COVID, segundo faixas etárias, chegava a ser até 20 vezes maior em relação à população geral. E era muito angustiante perceber isso na vida real. E, por exemplo, uma pessoa de 30 a 39 anos transplantada tinha o mesmo risco de morrer por COVID de que uma pessoa da população geral com mais de 60 anos. Uma das nossas primeiras iniciativas foi realmente, como a doutora Sheifali e o doutor Dorry mencionaram, trazer o acesso à informação e à assistência no tempo do lockdown. E assim foi criado pela primeira vez o Departamento de Telesaúde, que desde 2020 já realizou mais de 210 mil visitas por telemedicina, acompanhou até agora 3.504 pessoas com Covid confirmado. Isso corresponde a 1/3 dos nossos pacientes em acompanhamento. Nenhuma doença teve esse impacto nos nossos pacientes. Desses pacientes, a metade deles nós acompanhamos pelas visitas de telesaúde nas suas residências, mas a outra metade foi hospitalizada em alguma das 802 instituições em todo o país. E o trabalho colaborativo com os profissionais de saúde dessas instituições foi fundamental para o acompanhamento dessas pessoas. Mas mesmo assim, até o momento, nós tivemos 759 pessoas transplantadas renais que evoluíram a óbito, o que corresponde a um índice de letalidade de 21%, como a Tainá perfeitamente demonstrou, e uma mortalidade geral de 7% da nossa população transplantada. Para vocês terem uma ideia do impacto disso, a tuberculose, que é uma das principais doenças infecciosas graves que acomete a nossa população, ela tem um índice de mortalidade de 1,3%. Então, esse impacto é sem precedentes. E foi assim que nós desenvolvemos a primeira iniciativa brasileira institucional para vacinar contra o coronavírus a nossa população de transplantados, antes mesmo de que o Programa Nacional de Imunização colocasse como diretriz oficial a priorização dessas pessoas. Em um esforço absurdo, em 4 fins de semana, nós conseguimos vacinar 3.340 pacientes, que é 30% dos nossos pacientes em acompanhamento, inicialmente com a vacina Coronavac. A doutora Sheifali disse de acesso à vacina e das questões relacionadas aos países em desenvolvimento. É uma vacina de vírus inativado que tem facilidade de transporte, facilidade de manutenção e é muito mais acessível do que as outras plataformas. Como eu disse e agradeci no início, mais de 300 voluntários participaram desse projeto para viabilizar a vacinação desses pacientes e as visitas subsequentes para coleta de amostra de sangue, os inquéritos para avaliar a reactogenicidade e a ocorrência das infecções. E os nossos resultados, que eu vou apresentar brevemente nos próximos 10 slides, orientaram as próximas diretrizes do Programa Brasileiro Nacional de Imunização para o paciente imunossuprimido. E é um orgulho para mim, nesse momento, estar compartilhando esses resultados com vocês. O Dr. Segev colocou, e os nossos resultados são bastante equivalentes, a soroprevalência com a vacina Coronavac entre os pacientes que não tinham sido expostos à Covid, nós tivemos o cuidado de confirmar uma sorologia negativa imediatamente antes da primeira dose, e aqui eu trago a soroprevalência acumulada dos pacientes que tomaram as 4 doses de Coronavac e que não tiveram Covid confirmada entre as vacinas, alcançou 65,8% após a 4ª dose. Após o regime inicial proposto de 2 doses, a soroprevalência era de apenas 35,4%. E eu peço que vocês guardem esse número, 65,8%, porque agora nesse slide eu vou comparar a imunogenicidade da vacina, a soroprevalência das doses acumuladas entre os transplantados, que está aqui em azul, são aqueles números que eu coloquei no slide anterior, e eu vou comparar agora com pacientes em diálise que receberam a vacina Coronavac também como parte da nossa iniciativa. Foram 200 pacientes em diálise que alcançaram 91% de soroconversão com 2 doses de Coronavac e com colaboradores da nossa instituição que também receberam a vacina Coronavac e alcançaram 98% com regime tradicional. Então, mesmo com 4 doses da vacina, os pacientes transplantados não atingem os índices de soroprevalência nem da população geral e nem mesmo das pessoas em diálise crônica. E a situação fica ainda mais sombria quando nós avaliamos os títulos de anticorpos. O Dr. Segev demonstrou a relação, não é, entre os títulos de anticorpos e a relevância clínica disso. E os pacientes transplantados, novamente aqui demonstrados em azul, apresentam muito baixo risco, muito baixo índice de anticorpo entre aqueles que soroconverteram após as doses da vacina, muito menores do que as pessoas em diálise ou os colaboradores sadios da instituição. A próxima iniciativa que nós tomamos foi realmente a combinação de plataformas. E nós tivemos a oportunidade de testar se a 3ª dose heteróloga com a vacina da Pfizer-BioNTech teria um desempenho melhor em relação a permanecer com 3 doses da vacina Coronavac. E esse slide, ele, para nós, é um desafio, e eu já vou explicar o porquê. O regime heterólogo, que agora está nas barras azuis, ele se associou a uma maior taxa de soroconversão, de 48,9% contra 32,4% até após 3ª dose, uma soroprevalência final maior também, títulos de anticorpos 10 vezes maiores do que quem recebeu a terceira dose homóloga, mas aqui vem a curiosidade e o que nós ainda precisamos entender melhor. Entre os pacientes soroprevalentes, 98% daqueles que receberam regime heterólogo testaram positivo para a atividade neutralizadora, mas 94%, e essa porcentagem foi semelhante entre os dois grupos, entre os pacientes que receberam regime homólogo com Coronavac, também apresentavam atividade neutralizadora dos anticorpos. Então, embora a mistura de vacinas tenha se associado a títulos maiores, não se associou a uma maior porcentagem de pacientes atingindo atividade neutralizadora desses anticorpos. O que isso significa, nós precisamos estudar melhor, nós precisamos estudar com mais detalhe, talvez quantificar isso e verificar a durabilidade da imunogenicidade, mas é um desafio que vai ficar para os próximos encontros. E como o Dr. Segev mencionou, nós também tivemos a impressão, aqui é uma coorte um pouco menor, mas também nós tivemos a impressão de associação entre a soroprevalência e a efetividade clínica. Dos pacientes, então, que haviam sido vacinados com 2 doses, a incidência de COVID, a partir de 15 dias e até 3 meses depois da vacina, havia sido de 5%, e a letalidade global dessas pessoas, foram 45 pacientes, foi de 13%. Mas, se dividirmos esse grupo de 45 pessoas entre quem havia apresentado soroconversão após a segunda dose, entre aqueles que haviam permanecido sem resposta humoral, os óbitos se concentraram entre aqueles soronegativos. Então, não houve óbitos entre os 23 pacientes que adquiriram COVID pós segunda dose, mas haviam tido soroconversão, e os 6 óbitos aconteceram entre aqueles pacientes soronegativos. Muito bem, chegou o ano de 2022 e chegou um novo desafio. E como a Omicron mudou esse panorama? Esse slide, para mim, é muito significante. Eu trago para vocês as taxas de letalidade mensais desde o início da pandemia no Brasil, que foi aqui no nosso centro, que foi em março de 2020, no estado de São Paulo. Apesar do primeiro caso ter sido reportado 26 de fevereiro, mas o nosso primeiro caso em transplantado foi dia 20 de março. E aqui eu comparo com uma coorte de pessoas de um município do estado de São Paulo de 14 mil habitantes. É um município com tamanho muito parecido com a nossa coorte de 10 mil pacientes transplantados. É um município que teve uma política de testagem muito semelhante à que nós desenvolvemos aqui na nossa coorte de transplantados e que reflete muito bem a realidade brasileira. Então, primeira mensagem desse slide, as barras em azul demonstram que a letalidade por COVID ao longo dos meses, ela não pareceu ter influência das doses adicionais de vacina. Se foi pela baixa soroprevalência após a vacinação, é uma das nossas principais hipóteses. Enquanto que na população geral, se vocês perceberem a partir de agosto, que foi quando o Programa Nacional de Imunização completou a terceira dose entre as populações de mais alto risco no Brasil, não houve óbitos na população geral por COVID-19 até dezembro de 2021. A segunda mensagem desse slide é o provável escape imunológico da Omicron. Então, após os 5 meses sem óbitos na população geral, voltamos a observar óbitos. Aqui, esses óbitos se concentraram entre pessoas mais idosas, e foi de 0,4% versus 2% nas ondas anteriores. E a terceira mensagem é que a terceira onda, como a Tainá mencionou, sim, se associou uma redução brutal da letalidade nos transplantados, mas ainda uma taxa proibitiva. 1 a cada 10 pessoas que adquirem COVID, transplantado renal, evolui a óbito mesmo nos dias de hoje. Então, eu termino a minha apresentação com mais perguntas do que respostas, e o futuro, na minha opinião, vai precisar responder pelo menos essas perguntas, que seriam quais alternativas nós teremos de imunização para esses pacientes sem resposta aos boosters de vacina. O Dr. Segev comentou a 5ª dose. Será que nós teremos algum efeito benéfico dos novos anticorpos para profilaxia pré-exposição? Qual é a imunogenicidade e a efetividade das vacinas disponíveis para as crianças transplantadas? Eu acredito que no congresso da TTS nós teremos os nossos dados dos nossos pacientes transplantados pediátricos que receberam as vacinas da Pfizer. Qual será a periodicidade das doses de reforço nesse cenário mutante de variantes emergentes e epidemiologia absolutamente imprevisível? No Brasil, nós ainda não temos disponíveis prontamente terapias eficientes para quem adquire a doença. Isso é um ponto que o futuro vai precisar resolver. E eu não posso terminar a minha ponência com uma provocação para nós brasileiros, porque em 2022, com toda essa tecnologia e com toda essa rede, nós ainda não temos uma regulação definitiva para a telesaúde, e, na minha opinião, não é possível seguir evoluindo sem que as questões estejam completamente regulamentadas. Então, eu gostaria de agradecer muito. Vejo vocês em Buenos Aires. Thank you. See you in Buenos Aires. E estou à disposição para comentários e perguntas.
Thank you, Marina.
Muchas gracias.
Well, now we have 20 more minutes to discuss this huge amount of data that we heard here, Marcelo. And we already have Doutora Maria Cristina with her hand raised. Maria, Cris, welcome.
Do São Paulo.
From São Paulo. Just a second, I'm gonna.
You're muted, Maria.
Just.
She may not be able to unmute.
No, she is. I just.
See, Marina, when you said U.S. Cowboys, I thought you were going to play the MC Fiotti song. Marcelo, do you know about this?
I couldn't hear. Say that again.
Brazil had a rap song, a famous rap song,
Yes.
supporting the vaccine. We had nothing like this in North America.
Oh dear, I'm behind rap music. I'm sorry.
Well,
That's true, Dorry. You made one.
Well, yes, but I'm not MC
Yeah.
Fiotti. I didn't get 1.5 billion views.
So Marcelo, so what about here we did two analyses. We have a Brazilian analysis and the world analysis. And Sheifali just showed us the difference on low-income countries for the impact of COVID. And we really did, just like Tainá showed us, the impact of this in our country. We were one of these low-income countries that really suffered from the impact of COVID in the last 2 years. So how was Canada dealing with this problem the last 2 years?
I would let Sheifali answer that question.
I think Brazil falls under the upper middle income country, and so it sort of is in the middle. I think there are some programs that were even worse off. So in Canada, it was exactly what our survey predicted. Our program, we were able to maintain 75% of our transplant volume. We had to cut back on transplantation initially, but eventually we were able to, I mean, in our program, Marcelo is our director. He was able to rally the troops and be like, listen, we need to continue our transplant programs. And so did several other centers. We were able to ramp up our living donor kidney transplant program even before the year ended. This obviously wasn't the case with other programs. About COVID, we still have COVID. We always have had COVID. It's just not going away. And unlike many other countries, and I don't know how it is in Brazil, you know, I come from a place where you don't question, you just do. Like when somebody offers you a vaccine, I just remember, I grew up in India. There was a huge line for people to go get a vaccine. There are people in India that, you know, my husband was joking, apparently got 10 vaccines because they thought that getting more vaccines would protect them. And then I get into arguments here where vaccines are so readily available with my patients, and I argue with them for 10 to 15 minutes. I show them the data and they still say phrases like, it was developed too fast, I'm still not confident in it. And that kind of misinformation and that kind of, like, if I may use the word privilege, is something that I'm so not used to, that I you know, like vaccines save lives, like they do. People need to go to countries where the number one cause of death is not cardiac disease, is actually infection. And when you see that, then you really, like, if you live in, if you grew up with that environment, your take towards vaccines is so much different than it is in Canada. So I come from a country where I think the transplants, I think we're back to our normal, but what we're suffering with is this misinformation, and our patients are really impacted. Their care has been impacted. I've seen patients die. I have seen, you know, like it's actually in the news, we've seen pregnant women on ECMOs and their babies being delivered premature because they didn't take the vaccine. So I would say in our region, what's killing people is misinformation more than anything else. We're at that point now, which is obviously not the case with other countries, I would say.
Gustavo, thank you, Sheifali. I would like to add something. We did shut down our program for about 3 or 4 months, as many others in Canada. And in retrospect, because it was a little bit of the unknown. There was a big fear factor. And then we learned. We thought when we designed that survey that there was going to be a ramp down and then a ramp up. But we have been going down and up and down and up. But the ramp down has been less and less and less. So we did learn. There has been a learning curve. We are not quite to our usual number of transplants, close, but almost. And until about, not sure if it was November or December, when the Delta variant affected people, we were so proud to say that we had not had any new kidney transplant or any other organ recipient, kidney, liver, heart, pancreas, with COVID-19 until the fall of 2021. Correct me if I'm wrong, Sheifali and Dorry. We were not seeing any the COVID in de novo patients, in the novo transplant patients. We were very cautious. They were very cautious. But then we were seeing COVID as in people with morbidity, et cetera, But then we started having COVID in November and December of 2019, and we went from about, we do about 120 transplants per year, so a kind of a moderate-sized program, mostly deceased, 15 to 20% living donors, kidneys, and we saw a dramatic increase from about 40 patients. We follow about 1,000 at the clinic, and we went up to almost 300, to mid 200, almost 300, very rapidly. But very few people die. We still see people that die. We have about 5 patients in the ICU today, for instance. I was rounding 5 patients in the ICU, all with COVID.
Great. Dorry, how hard, we know that the vaccine had a really political problems in the US, and how hard was to get your patients vaccinated on US?
Well, we have vaccine hesitancy coming from multiple ideologies. Some was political. So the further right on the wing somebody was, the more they got bombarded with misinformation about vaccines and were part of vaccine hesitant communities. But for the most part, my experience with transplant patients, not just at our center, but all over the country, because, you know, as soon as we launched this study, all of a sudden I have, you know, 15,000 Twitter followers, all of whom are transplant patients, all of whom are desperate for immunity, and all of whom are freaked out that they don't have as much immunity as their immunocompetent counterparts. So the sentiment I got for the most part in the transplant community was that people were doing everything they could to achieve some sort of immunity. And I, you know, like Sheifali was describing, we have transplant patients in our study who had 6 doses because, you know, they kept trying to get doses and checking their antibodies and realizing that they weren't adequate. So the sense that I got overall was that the majority of transplant patients were trying desperately to get immune rather than trying to avoid vaccination. And in the centers that have, so more than half of transplant centers in the US now have some sort of vaccine mandate on recipients. And in the centers that have vaccine mandates, you know, you get 1 or 2 patients, 1 or 2 who will fight you to the end of the world about getting vaccinated. And both of those had Delta and then Omicron again, because they were unvaccinated and, you know, they refused to get vaccinated. And so they got Delta and then they got Omicron. And for them, you know, they have really good natural immunity and high demonstrable neutralization. And, you know, people even make exceptions for those patients. But for the most part, we have not heard, you know, it's been a handful of very, very loud people, but the majority have been very vaccine supportive. There was a recent article in the Atlantic that said, oh, all of this messaging that the vaccines are not adequate in the immunocompromised has created a lot of vaccine hesitancy. But I actually completely disagree with that article, and I got into a little Twitter fight with the author of that article in the Atlantic, saying that, you know, we just didn't really see that, because the immunocompromised have felt from the very beginning like they have to fend for themselves and they have to do everything they can to protect themselves.
In our center here, we had the same vision of it. Did you think about what about you, Marina? What's your expectation on your patients? Did they want to get vaccinated or not? Most of them.
For sure. Most of them phone us asking when is going to be the next dose, the 5th dose, the 6th dose. And they get angry with us when we answer, not yet, we don't know. We did not have problems with refusal. I remember one patient out of these 4,000 patients who refused to get vaccinated.
I don't know if you know that, Marcelo, but we have a president here in Brazil that didn't get vaccinated. So this is an issue for us here. So
we had a president who got vaccinated and then told everyone not to.
That's worse.
That's worse.
And again, we do at our center. I think about our center. We do respect people that don't agree with the vaccine for whatever reason, and we have not excluded those patients from the waiting list, or we have not denied transplantation. But again, they get COVID. One of the patients in the emergency room is one of those today at our institution.
We respect them in the same way we respect people who don't want to get a cardiac stress test. We say we respect that you don't want to get vaccinated, but we also don't want to transplant you.
So, Tainá, what about our data, Brazilian data on the last months? So, because here in my center, we are completing the first month without any COVID here.
Yes.
First time since the start of it. So how is our registry?
Here in Ceará, nowadays we have 30, 40 cases per day in general population. In transplant patients, I remember one case last week. But fortunately, COVID-19 is not a problem nowadays. Our problem nowadays is dengue because we are at the end of the rainy season. So our problem now is dengue, COVID, fortunately no. And despite all efforts of our president to induce our people not to get vaccinated, our people, Brazilian people loves vaccination, love got vaccination. Yeah, so fortunately.
Yeah, Brazil has a very good vaccination program.
Very
this
solid.
Is one of our.
Like,
We have
if I
here
may
in
add,
our room.
I think it has to do with the fact that infectious disease is so common there that people have seen relatives die of infectious disease, that, you know, people believe in vaccines, so they are more inclined, because it's the same in India. People die of malaria, dengue, TB, and other endemic infectious diseases much more. So most people are quite open to getting vaccines. This is really a first world problem, vaccine hesitancy, because I think people are forgetting or haven't seen like infectious illnesses.
Great. We have here in our room Dr. Ligia. She's the director of the COINT. The COINT is the Infection Commission from ABTO. Can you hear us, Ligia?
Yes, are you hearing me, Gustavo?
Yeah, sure. We'd like to
Okay.
hear your comments on this presentation.
Thank you very much, Gustavo and Marcelo. I'm so sorry not to be able to participate in this webinar, but I've just arrived in São Paulo from the European ID Society meeting in Lisbon. So, but congratulations for all the speakers. And it's a really important topic. We have learned a lot since the beginning of this pandemic. And we know that the COVID is not a single cause, especially in our patients and immunocompromised patients. And the vaccines work, and they work in our patients as well. But for sure that we need a better strategies, and we don't know exactly which strategy will work better. And probably new vaccines for protect our patients. So that's a great discussion, a great topic, and I also would like to invite the attendees to participate of TTS. And in the TTS, we receive a lot of papers regarding this topic, COVID and the ID issues, and it will be a pleasure to discuss deeply in Buenos Aires. So congratulations, and I think we are moving to a better coverage of immunization in Brazil, but unfortunately, we had the Omicron with most of our patients with 2 or 3 doses, because we started vaccination a little bit late. We, as Marina said, we started our vaccination program for immunocompromised patients around May, and we had Omicron and a huge number of Omicron infections with most of our patients not appropriately protected. Thank you very much, Gustavo, and congratulations.
Thank you. Thank you, Ligia. Thank you very much. We also have here Dr. Davi from São Paulo. Davi, can you hear us?
Yes, I can. Can you hear me?
Yeah, sure.
Thank you, everyone, for the presentations. I have a question for Marina. Marina, if you have all vaccines platforms available for kidney transplant patients in Brazil, which one would you recommend for the next vaccine campaigns?
I think that's a $1 million question. Well, Davi, se eu não tivesse estudado a Coronavac, eu rapidamente lhe responderia que eu usaria um regime heterólogo, ponto final, e não teria preferência sobre as plataformas RNA ou vetor viral para compor esse regime heterólogo. Mas o fato de que, com a terceira dose, Coronavac ou Pfizer-BioNTech, nós atingimos uma porcentagem semelhante de pacientes com atividade de neutralização positiva, me faz titubear nessa resposta. A Coronavac é uma vacina acessível, é uma vacina de muito fácil armazenamento, transporte, para um país como o nosso, de dimensões continentais. Eu ousaria dizer que seria a vacina que estivesse disponível no posto de saúde mais próximo da residência do nosso paciente. Mas eu posso estar errada. Em COVID, nós aprendemos que nós não podemos fazer previsões e que as verdades não são absolutas. Mas eu arriscaria dizer, do ponto de vista de saúde pública, que seria a vacina que estivesse mais facilmente disponível.
Thank you, Marina. Dorry, any thoughts on David's question?
Well, the real question is, will Anita advertise the Pfizer vaccine? Because if that's the case, then you'll get great Pfizer usage there. Now, I think I heard Marina talk about heterologous approaches, and I think that that's what's really going to be important. We have learned, even with the J&J vaccine that we had, that was as a primary vaccine, not particularly effective, but as a heterologous booster was very effective, more so than the mRNA platform. So I think if multiple platforms become available in Brazil, my recommendation would be to explore heterologous mixing of those platforms. I think really the next step from any of these companies, and I hear rumblings that this is happening, is to have variant specific additional doses, so that as the variants evolve, the substrate in the vaccine evolves as well.
I would like to ask a question to Marina, Dorry, and the rest of the panel and the audience. Is there any evidence about the nanoparticle vaccines, the Nanovax vaccine, produced from the city you used to work, Dorry, in Maryland? I'm saying this because someone very close to me got it because of a personal choice, and this vaccine apparently has an activity against the variants. Not sure if they knew about the Omicron when they conceived it, but do we have any data in transplant recipients? Because the very little thing that I read was that obviously this is the company proposing this as a potential booster for all of us, the ones that we got the RNA. So I got 3 doses. I'm entitled for the 4th one later on of Pfizer. Other people got 4 already, and other people didn't get because of recent COVID infection. So many, we don't need to ask, but I'm sure that many of the people attending had a very mild COVID not long ago, and those individuals will not receive the RNA vaccine. And perhaps there will be more data about the RNA, about the nanoparticle vaccine. Do we know anything?
So we've been begging the company to do studies in transplant patients for a year now. Obviously, a vaccine platform that relies less on intracellular machinery to produce the proteins that then generate the antibodies is a better, theoretically, a better platform for the immunocompromised. Who knows if it will actually prove as such. But as far as I'm aware, there are no data in any immunocompromised populations for this platform, despite more than a year of excitement about this potential. There have been a lot of regulatory snags that the company had, which is sad because it could be, we really need that kind of platform for our patients. We need a platform that does not rely on the intracellular machinery.
Believe it or not, it's approved in Canada and not in the States. It was approved in the UK, in Australia, and in Canada, there were some regulatory issues that delayed the approval. So it's going to be produced, and the first 100,000 doses came from the Serum Institute of India, Sheifali. So I'm really looking forward, because this is not going to go away. I'm not sure if we'll continue counting the waves. Maybe I'm not sure how many thousands of cold waves and flu waves has been around in the world. So at some point, I think we're going to stop counting the waves. And I heard that in the States, the pandemic has been declared as over. Is that correct, Dorry?
The word over is thrown around a lot these days, but I don't think anybody knows what it really means. But certainly, if you walk around the streets of New York, you would not know that we still have 50,000 new cases a day in the United States.
Okay.
Thank you. Well, I think that we ran out of time, so I would like to thank you, everybody that got their time here with us tonight. So hope we can see everyone in Buenos Aires in September. And Marcelo, thank you very much for your time. Thank you, Dorry. Thank you, Sheifali. Thank you, Tainá, and thank you, Marina. And thank you all the others that came here with us tonight. Thank you very much. And bye-bye. See you next time.
Bye-bye.
Gracias.
Ciao, gracias a ustedes.
Bye-bye.
Bye-bye.